Good afternoon, everybody. Well, a few people are still coming in. It's 4:15 and it's time to start the session on gynecological cancer. My name is Wim Ooyen. I'm a professor of nuclear medicine and molecular imaging at the Institute of Cancer Research in London. And it's my pleasure to share this session together with Professor Michael McKay. And we now shift gears from PET-MRI and PET-CT towards sentinel lymph node scintigraphy in gynecological cancers by my good friend Francesco Giamarella, who was a professor of nuclear medicine in Lyon and is now working for IEA in Vienna. Francesco, please.
Thank you very much, Wim. So, dear friends and colleagues, I will speak about sentinel lymph node, and in particular about the ENM guidelines on this topic. I just have two rapid questions from the beginning. Who is performing sentinel node technique in general, not focusing on... Yes. And who is performing the technique for gynecological cancers? Yeah, so it's about 10%. And I think it's a little bit this survey reflect what's in the world in our community. So I will speak first of all about common aspect in introduction, the present with the ENM guidelines and some future trends. I have no conflict of interest in this particular topic, and those are the guidelines. The guidelines, what I wanted to stress is that they were endorsed by the International Federation of Gynecological and Obstetrics, so the FIGO, by the European Society of Gynecology and Oncology, ESGO, and the Society of Nuclear Medicine. So this is to say that if we have to do some guidelines, it's always very interesting to have some opinion of our friend clinician, because there are some technical and clinical aspects that we need to have from them. The topic are essentially focused on vulvar cancer, cervical cancer, endometrial cancer. We will have not much to say about vaginal cancer, even if it's interesting, but the studies are too less. And ovarian cancer, for the moment, the issue are requiring further clarification, also because the technical of sentinel node with the injection in the tumor is rather complicated. So the first aspect is the lymph node in pelvic region. We need to know clearly anatomy in order to understand then what our images, and especially the surgeon needs to know exactly which lymph node have and which stage. Also because of what said before on the clinical aspect on PET-CT, the different stages is fundamental for prognosis and also for therapeutic aspects. The sentinel node concept, I think everybody knows, so I will go very quick, is the first node involved in metastatic spread of tumor. And if you use radioactive compound, you can from outside look at this sentinel lymph node that is hot, and the other are normally cold. So this is the principle. What we use is radiopharmaceuticals. Some are used in also here that are antimony sulfide. Some are used in Europe. The interesting is that these colloids are essentially the same that are used for lung, but they are a little bit bigger, and they to see the reticulum endothelium system. This is to say that the uptake is completely non-specific for these radiopharmaceuticals. We will speak later on a new trend with a new radiopharmaceutical that is much more specific. Those are not specific. And what is the only thing that we should do, and is fundamental to say, is to look at the quality control, because if the quality is above 95%, then we will see too much reticular endothelial system, and the images are not good quality. So the imaging modalities, we can have planar or dynamic. We can have planar with landmarks. That could be interesting if we don't do SPECT-CT. That is maybe the best image for the anatomical aspect. We can use also portable gamma camera that is of particular importance in this tumor where laparoscopic surgery is the main therapeutic indication, or we do also nothing. And there are people who are only injecting the radiopharmaceutical and then checking with gamma camera, so with gamma probe, so without using gamma imaging. What we should say that there is no consensus in the guideline, but clearly we are for the imaging. This is clearly why there is no consensus, because for some particular indication of, for instance, uterine cancer, sometimes the injection is done during the interventional time. So clearly, if there is no portable gamma camera, we cannot make image. This is the reason why. So now the SPECT-CT, the general indication is when planar images are difficult to interpret. So clearly, if we have unexpected or unusual drainage patterns, if we have poor visualization of the drainage, especially in overweighted patients, if we have areas of deep lymphatic drainage, like, for instance, our case than pelvis. Clearly, the advantage is the better contrast and spatial resolution, also because we do attenuation correction, so for deep lymph node is really the best way. Clearly, we have the anatomical help, so we can better understand the situation of the lymph node. The problem is, the first is the cost, at the time, the added radiation, and clearly is not possible to use for dynamic studies. This is an example of CT that can clearly analyze the situation of the lymph node, and the guideline says that the hybrid imaging with SPECT and CT improves the localization of sentinel node and reduce misinterpretation of image. So it's clearly an advice, it's not a recommendation, but if we can, SPECT-CT is the best way to do. For surgery, we have normally endoscopy, so the gamma detection has a long probe. We have a protective cover of the probe, and the lymph node is then extracted. Generally, we use, like in this case, also blue dye, we'll see later on. And so the node is hot and blue. Another aspect is the surgical attitude. This is also something that could be interesting for us to know, is that if the lesion is monolateral, then the dissection is monolateral. But if we have a contralateral sentinel node, we will pick up this sentinel node. So even if the lesion is monolateral, if we look for a sentinel node and we see a sentinel node in the other part of the body, hemibody, then we will try to search for this sentinel node. If clearly the lesion is bilateral, then we have a bilateral dissection. So this is the general rule for surgery that we should know in order to clearly indicate to the surgeon if there is some sentinel node that is not on this aspect. So we start with the vulvar cancer, that is the least frequent gynecological malignancy. This is the stage 1, 1A, 1B, and 2. And with the staging system, T1, T1A, T1B, and T1-2. And the sentinel node is interesting from stage 1A and 1B. The reason why sentinel node is interesting is because of prognostic value of regional node state that is already been said before. In 30% of cases, the woman has nodal invasion, and the five-year survival rate is from 94% if the lymph nodes are negative to 62% if they are positive. So it's really important to have this notion. The problem of inguinofemoral lymphadenectomy is a very high morbidity. It's a terrible morbidity. You can see the results of this surgery. So the sentinel lymph node is, like for the breast, a way to decrease this surgical morbidity. The sentinel node has superficial and deep lymph drainage, but generally the lymph nodes are in this position, so they are not going up on the orthofemoral region. The procedure, so normally we can suggest to give lidocaine spray in order to reduce the pain of the injection. The tracer activity is from 20 150 in 2 to 4 injection. Why the activity is so wide? Because there are essentially two ways to do the procedure, like for the others. We can do on the same day or the day after. So if you do the day after, you have to increase the activity. The injection is superficial with a small syringe, and the acquisition we can do dynamic and static. We can use fluid sources if we want to have nice images. If we do SPECT-CT, clearly we will not use the floor. We don't need essentially this nice image. So these are the characteristics. I think the slides are available for you, so you can use it. So this is an imaging of unilateral drainage. That is, so for vulvar cancer, clearly vulvar can have is a bilateral organ, so you can have unilateral, or if it's in the middle, you can have bilateral drainage. So this is a case of unilateral drainage, and this is a case of unilateral, early, and late bilateral. So this is the importance of looking at, sorry, this is the bilateral, and this is the early unilateral and late bilateral. So here, it was at 5 minutes, it was only one side, and at 30 minutes, the second side was appearing. That is clearly evident at 2 hours. So this is the reason why we normally do early 30 minutes and late 2 hours image. This is what is our protocol, but it's not clearly it's not recommendation. Here we can see also often contamination because of the injection is not always easy to perform, and some drops come out after injection, so they follow this, and they can, for gravity, you can find it in the back of the patient, and you can see also the second national node that is different from the sentinel node that was the first noticed at the beginning. The SPECT-CT is really very interesting because you have here the injection side and here the sentinel node that you can also look at CT, because CT can also give you an idea of the aspect of this lymph node. So this lymph node is small, this is enlarged, so you can understand that the enlarged lymph node is much more suspicious. The surgery. So normally we use blue dye, so that the node is hot and blue, is removed and controlled after, and the results, the quality of life clearly is a much better quality of life on functional and symptomatic way if you do a sentinel lymph node or if you do the lymphadenectomy. This is also the results of the clearly the detection rate is 0.87, so it's a very interesting detection rate of sentinel lymph node, and the false negative rate, that means the patient who have a negative sentinel lymph node but a positive lymphadenectomy is 6%. So it's also something acceptable for the patient. Now we move to cervical cancer. That is the third most frequent gynecological cancer, but is the primary cause of death in women of childbearing age, and is the first low to middle income country cancer because of hygienic rules. So this cervical cancer is very often found in those countries. We have also the staging, stage 1B, stage 1B, and stage 2B. So for the stage 1B, the connectomy is possible, so the removal of the tumor. For later stage, the surgery is performed, and in this case, we do also sentinel lymph node. What is very interesting and very important to say for cervical cancer is that generally what is done in nuclear medicine is very good that we do ourselves. So if you want to make cervical cancer sentinel lymph node, it would be the best if you learn how to make the injection yourself in the cervical cancer. So I think that the patient should come and you should be able to use it was in the, yes, here, use the system in order to see the cervix and then to inject yourself. For stage 1A1, the nodal invasion is more than 1%, so there is no lymphadenectomy. But in the others, early stage, so from 1A2 to 1B1 and 2A1, the pelvic invasion is from 11 to 21, and so you have, like for vulvar cancer, you have the need of doing sentinel lymph node in order to avoid the lymphadenectomy. Lymph drainage is a little bit higher than for the previous cancer. You can see even sacral nodule and junctional nodules. But the most frequent location of pelvic nodal metastasis is the obturator group, followed by the external iliac basin. So the procedure, as said before, it would be the best to do yourself. Clearly, at the beginning, you need to ask the help for the surgeon or the gynecologist, but the best would be to do yourself. You can inject in 2 or in 4 sites. The activity is rather the same than previously, 2 to 4 injection. In this case, we don't use the lidocaine because the pain is less important. The acquisition is the same, and SPECT-CT is also recommended. So this is the aspect. Normally, we don't use the lead shield of the syringe because of hygiene reason. So this is the example of common iliac nodes that are seen here, and external iliac nodes that are a little bit more external than this one, that are a little bit higher. In imaging, you can have also in this case unilateral drainage, even if you make the 4 injection around the clock, or more commonly bilateral drainage, or no drainage at all. This is also sometimes happens. But this is not a reason not to perform the detection, because clearly the gamma probe has a higher resolution than the image. SPECT-CT is very useful, and we can perform just after the planar image. So I go a little bit quicker because I'm a little bit in late, I think, because I have also to speak about the uterine. So these are the results we have. That is a very interesting article published in 2013. 35% of cases we have unexpected areas of drainage. So this is very useful for the surgeon to know that you have also other areas that is external iliac and interiliac. And for the results, we have a detection rate of 0.88% if you use only the radioactive, and if you use the combined, so blue and radioactive, you have 0.997. So that is very interesting. So that's why blue dye injection is recommended. The surgical procedures, you inject the blue dye, then the detection, and then the ex vivo counting. So now we move to endometrial cancer. That is the third and last of my presentation. What is very important to say is that endometrial cancer is not the same as cervical cancer, especially, not only because, but since we are speaking about sentinel lymph node, especially for sentinel lymph node drainage. So the problem is that the injection of endometrial cancer in the tumor is very difficult, complicated. So that's why there are several possibilities to do, and there is no consensus of what is the best to do. Clearly, the best is to inject near the tumor, but it's not always easy to do. Here we have stage 1A, 1B, and 2, and from stage 1A we can use as sentinel lymph node. If the endometrial cancer has a low risk, there is very low incidence of novel invasion, so there is no management consensus. So we don't know if to inject or not sentinel lymph node. On my opinion, we should have this in young patients that are more at risk of, but this is not a consensus. So there are different reported injection ways. The first is the cervical injection. If you inject exactly like cervical cancer, this is the easiest we can do ourselves. So but it's not at all physiological because we don't see the endometrial lymphatic, but we see only the cervic lymphatic. The second is the endometrial peritumoral that is assisted by hysterectomy. This is the best way to do, but it's also very complicated. We can't do as nuclear medicine. We can do in nuclear medicine department. We have to do in surgery. So without imaging or the day before. So it's not very simple. And another one is the subcerebral myometrial injection. We go through the to the vagina, and this also is a complicated system. Is a little bit the same system that is used for assisted I don't know to have children. The woman who can't have children have the assist. So the ovule is injected in the same way. Yeah. So there is no consensus. What I want to say is that normal, you have very high lymph node that you will very rarely see if you inject in the cervical region. And those nodes you will miss if you inject in the cervical region. The other system is the same. So this is the importance that the lymph nodes are not the same. You see the lymph system sentinel node of vulva, of cervix, of endometrium. It's not the same. This is, I think, if there is one message to remember is this one, that if you inject in cervical region for endometrial cancer, you have to pay attention of possible false negative, sorry. Now, the endometrial injection during hysteroscopy is the one that is the most simple. The problem is that it has to be done in a surgical room. Normally we do just before surgery, so you have no imaging unless you have not the portable gamma camera on the surgery. Or you can do the day before, but in this case you need 2 anesthesia. I don't think it's really the best way to do it. So this is the results, and the results have very nice sentinel node detection. The second is the subcerebral myometrial injection is doing during surgery. Normally is how is injected the blue dye. You see is done via a transvaginal endoscopy, and you inject the method. This also is not possible to do in nuclear medicine by nuclear medicine physician, but it could be done in nuclear medicine department if you have a specific way. And I know that in some Spanish nuclear medicine department they do that. This could be a good solution to have. And also in this case, the sentinel node detection is interesting. The most common is the cervical injection. We do also this kind of things. Is done, the only thing that we also inject in deep. This is a way to differentiate between the cervical cancer. We also inject, we have 2 superficial and 2 deep injection. We don't know if it reflects the real endometric drainage. There is 2 contradictory results. One is the result of a French multi-center studies called Senti-Endo, that say that the negative predictive value is 97% and the sensitivity 84%, so acceptable. The other is a paper from Cornier, who says that the number of detected lymph node is clearly very low in para-aortic system. So you miss clearly some para-aortic metastasis. For imaging, no sentinel lymph node. Imaging with difficult to interpret, early and late imaging. Clearly, in this case, the SPECT-CT is more than interesting. And so the new trends, just to, simply, clearly like in nuclear medicine, we have 2, so the surgery, yes, I forgot, is always the same. You have the method and you have the tracer, clearly. in nuclear medicine, we can progress in method and in tracer. For the method, we have the small field of view portable imaging that is really very interesting, especially if you do uterine cancer. For vulvar cancer, you can use also in order to assess the completeness of the sentinel lymph node removal, like is seen here. I have lost my, yes, here. Here you see this lymph node was removed, and then the second one. Clearly, another way to do is to look for the progression of the gamma probe, and in order to look at the gamma probe during the gamma imaging, you can put the iodine seed, that is the one that is used for prostate cancer treatment, brachytherapy, and then you see where the gamma probe is, and you can go in the direction of the lymph node. For cervical cancer also is the same. You can use also a mixed reality surgery, that is a gamma probe with a tracking target, and you have the reconstruction in 3D, and in 3D you can also integrate SPECT-CT and look for the sentinel node that was present in SPECT-CT and localized in the patient. That is really the virtual, the 3D is a little bit like the Tamagotchi search, for the tracer, we have the fluorescent tracer that are essentially interesting for laparoscopic because we are in the dark, so you can nicely see them. Is normally indocyanine green, that is near infrared fluorescence. The problem of that is interesting in order to replace blue dye. The problem of this is that clearly while radioactivity goes outside the body, the near infrared stay inside the body. So you cannot check this if you are not really close to the signal. So the solution is to use a cocktail, bimodal hybrid agents that are on the same time radioactive and fluorescent. And in this case, you can have, and I have here an example if it works, yes, you can have the gamma detector, the light, when you see exactly where is the lymph node. So essentially, you replace, you use the fluorescence instead of the blue dye. Why to use something that is more expensive than the blue dye? There are two reasons. The first reason is that the blue dye is not always very well tolerated by the patient. And the second, most interesting, is that we have a cocktail. So we inject on the same moment the two tracer. So we detect exactly the same thing. While for blue dye, you have to pay attention on time, because while the radioactive you inject the day before, the morning before, the blue dye you inject during the surgery. So you have exactly to pay attention to take the moment of the stasis of the blue dye in the lymph node, otherwise you don't see anything. So this is the interesting of the hybrid tracer. I think I have finished. I have only some take-home message. It's good, no? So for vulvar cancer, indication is squamous vulvar cell carcinoma. Vulvar melanoma is also accepted, with the same indication as cutaneous melanoma. Sentinel lymph node has a prognostic value and a very interesting result in morbidity. For cervical cancer, early stage cervical cancer, the cooperation with the gynecologist at the beginning is fundamental, in my opinion. You have to learn how to inject. The results are excellent in detection rate. And when cervical tumor drainage is not bilateral, a pelvic lymphadenectomy on the territory without sentinel node must be considered. This is a recommendation of the gynecologist. Endometrial cancer, the indication are the following: is essentially stage 1 and 2 with high-grade nuclear grade, or stage 1 and 2 with G1, G2. The sentinel node is not a standard of care because we don't know exactly how to perform the injection. The results are promising, but there is a lack of consensus of the best injection modality. The contraindication of all these are clearly suspected extrauterine involvement, and in this case, the FDG is maybe one aspect that can be considered in order to have a pre-surgical assessment. The presence of pathological pelvic or para-aortic lymph node in the radiological exam. In this case, you are sure that there is a positive lymph node. Previous history of surgery or radiotherapy, and contraindication for surgical treatment. Future trend, new radiopharmaceutical and new instrumentation. So today is the birthday of my birth town, Rome. It's the 2770. So that's why I put this image. Thank you for your attention.
Thank you very much, Francesco. Are there any questions? Yes, please. Please come to the microphone.
I would like to congratulate Dr. Giamarini for this very interesting presentation. My question is, do you advise surgeons to remove all imaged hotspots like a sentinel lymph nodes, especially if they are bilateral?
Yeah. Yes, very, very interesting question. Thank you very much. Clearly, this is a general remark that is valid for all sentinel node procedure. So do we, on my opinion, we have to indicate all the hotspots, indicate, to give a probability of which are for you the most interesting to remove, because clearly you have the second echelon lymph node that are sure, so you indicate, but you also say these are second echelon, like we do on the image. Clearly on the spec CT, we indicate where are the, and what are the doubtful. So what are the sure? Clearly the surgeon should go. The doubtful, he can go, but or not, it depends on the position of the lymph node. But this is true for not only for gynecological, but for all the sentinel node meter. Thank you.
One more question.
In your experience, the second echelon lymph node, has it been positive in vulvar cancer or in the, in the cervical cancer?
By definition, if it's a second echelon lymph node, it could be positive only if the primary is positive.
Okay.
Okay, so thank you very much for attending this session. And once again, thank you very much, our speakers and my co-chairman. Thank you.